Hyponatremia. So there's a chart in Toronto notes. So we need to learn that chart by heart. So let's do that. So there are three basic causes of hyponatremia. Number one is hypoosmolar. Hypoosmolar, where the osmolarity is less than 280 milliosmoles per kg, less than 280. And then the other one is isoosmolar, where the osmolarity is between 280 to 295 milliosmoles per kg. And then there is another one which is hyperosmolar condition, where osmolarity is more than 295 milliosmoles per kg. In hyperosmolar, it is also known as translocational condition. And hypoosmolar likewise is also known as dilutional. Okay, so the causes of hypoosmolar are, hypoosmolar is the most common cause of hyponatremia. So number one is most common cause. Number two is excessive water retention. As the name suggests, there is water retention. Increase water retention, and in retention of water there is sodium stores which can be decreased, normal or increased, and categorized by volume status as determined by clinical assessment. So volume assessment could be patient could have hypervolemia, euvolemia, or the patient could be hypovolemia. We'll discuss the further causes of these later on, but first we will complete isoosmolar. So isoosmolar is between 280 to 295 milliosmoles per kg, and this is because of retention in ECF of large volume of isotonic fluid that do not contain sodium. So there is retention of isoosmolar fluid. And what is the isoosmolar fluid? That is mannitol. Okay, and there is another reason, that is pseudo hyponatremia. What is pseudo hyponatremia? It is lab artifact seen with severe hyperlipidemia, and it could also be seen with paraproteinemias. Paraproteinemias, that is multiple myeloma. Okay, and then in hyperosmolar, there is a serum osmolarity of more than 295. There is extra osmoles in ECF draw water out of the cell, diluting the sodium in the ECF. Extra osmoles in ECF draw water out of the cells, diluting the sodium in ECF. So there is increased water, usually glucose, rarely hypertonic mannitol. Every 10 millimole increase in blood glucose results in 3 millimole decrease in sodium. So that is increased glucose that may cause hyperosmolar hyponatremia. Okay, for every 10 millimole increase in glucose causes 3 millimole decrease in sodium. Okay, so we need to remember this as well. Every 10 millimole increase in glucose lead to 3 millimole decrease in sodium. Okay, now coming back to hypervolemia, euvolemia, and hypovolemia. Before coming back, we will just quickly revise the things that we have already covered, and that is hypoosmolar, where the osmolality is less than 280, and then isoosmolar 280 to 295, and then hyperosmolar more than 295. So hypoosmolar is dilutional, hyperosmolar is translocational. And then in hypoosmolar, there is increased fluid retention. Euvolemia, hypervolemia, hypovolemia are the further subclassification. But isoosmolar condition of hyponatremia, there is retention of isoosmolar fluid like mannitol. And it could also be pseudo hyponatremia, where there is two conditions, hyperlipidemia and pseudo paraproteinemias like multiple myeloma. And then in translocational, there is increased glucose retention. For every 10 millimole increase in glucose, there is 3 millimole decrease in sodium levels. Now coming to the volemia, euvolemia, and hypovolemia. So if the patient has hyponatremia with hypervolemia, so and there's sodium excretion of less than 20 millimoles, and FeNA, which is fractional excretion of sodium, is less than 1%. We know there is renal loss. Okay, and then it could be because of congestive heart failure, it could be because of cirrhosis, or it could be because of nephrotic syndrome, or it could be because of pregnancy, volume retention. So these are the causes where urinary sodium excretion is less than 20, and the FeNA is less than 1%. Okay, and then let's say urine sodium is more than 20 and FeNA is less than more than 1%. Then the cause of hypervolemia would be AKI, okay, and CKD. Okay, so we know the urinary sodium is more than 20 and FeNA is more than 1, that the causes AKI and CKD. Let's say euvolemia, there is urine osmolality of more than 100, then the cause is SIADH, all right, with normal urine sodium, and then also there may be adrenal insufficiency, and there could be hypothyroidism, and there could be urinary osmolality, let's say, of less than 100. If it's less than 100, then the causes are psychogenic, polydipsia, or it could be low solute, that is tea and toast. And this is more frequently asked in QE1. Okay, so urine osmolarity less than 100, urine osmolarity more than 100, then SIDH, adrenal insufficiency, hypothyroidism. If it's less than 100, then psychogenic polydipsia or low solute like tea and toast diet. Okay, and then let's say hypovolemia means urinary sodium of more than 20. Diuretics like thiazide diuretics. Okay, and let's say if there is salt wasting, nephropathy, and then if urinary sodium is less than 10 and FeNA is less than 1%, then this is extrarenal loss, where there is diarrhea, there is excessive sweating that can lead to loss of sodium, and third spacing. Okay, so in third spacing means peritonitis or pancreatitis. Okay, so let's just revise it once again. Okay, and let's just do it with initially, like let's say hyponatremia is sodium of less than 135 and then millimole per liter. So if sodium is less than 135, the most common cause is hypoosmolar hyponatremia. Hyponatremia is because of dilutional effect. There is more water retention. There is more water retention means hypervolemia, euvolemia, or hypovolemia. So if let's say sodium, we need to see the urinary sodium in hypervolemia. If urinary sodium is less than 20, FeNA is less than 1%, that is congestive heart failure, cirrhosis, and nephrotic syndrome in pregnancy. These are the four most important causes with low urinary sodium and low FeNA, fractional excretion of sodium. But if fractional excretion of sodium and urinary sodium is more than 20 and fractional excretion is more than 1%, then the two causes are AKI and CKD. Okay. And then if it is euvolemia, let's say, where urinary osmolarity is more than 100 or urinary osmolarity is less than 100. So in euvolemia, we see urinary osmolarity. If urinary osmolarity is more than 100, that means the patient may have SIADH, patient may have adrenal insufficiency or hypothyroidism, most likely related to hormones. SIADH, adrenal insufficiency, and hypothyroidism, these are the three important causes with urine osmolarity of more than 100, and euvolemia, hyponatremia. Okay. And then if urinary osmolarity, let's say, is less than 100, then there could be two causes: psychogenic polydipsia or low solute, such as tea and toast diet. Tea and toast diet and psychogenic polydipsia are the causes where urinary osmolarity would be less than 100. Okay. And now coming back to hypovolemia, we see urinary sodium. If it's more than, sorry, we see urinary sodium where urinary sodium is more than 20 or less than 10. If urinary sodium is less than 10, causes could be diarrhea, excessive sweating, and third spacing with peritonitis or pancreatitis. And if urinary sodium is more than 20, that could be because of diuretics or salt wasting nephropathy. Salt wasting and nephropathy and diuretics. So we need to learn this chart by heart, and entirely the hyponatremia would be covered from Toronto notes. Okay, and then the two important boxes that are: if urine osmolarity is unknown, assume urine is hypoosmolar or dilute, and symptoms of central pontine myelinosis based on the treatment of hyponatremia. So that would be covered in another video. So for now, we are just covering the table, the chart in given in the hyponatremia, and this is the most important part in the entire hyponatremia. Okay. So yes, thank you.